So that's a really good question, because there actually aren't any early signs and symptoms of prostate cancer when it is at its early curable localized state. As you read recently in the news, prostate cancer is now the commonest cancer diagnosis in England. It has overtaken breast cancer, and so it's a very common cancer that affects 1 in 8 men across the country, and that number doubles if you have a first degree relative like a father or brother with prostate cancer. That number doubles if you have Afro-Caribbean descent. That number increases for other ethnic risk factors like being Ashkenazi Jewish, etc. So it is a very, very common condition. And the key important message I want to convey is that it is without symptoms in its early curable stages. So you cannot wait for waterwork symptoms, which are a sign of benign prostate enlargement. They're not a sign of prostate cancer. You have to be proactive in looking for prostate cancer with PSA testing, which is a blood test, potentially examinations, and potentially some scans like an MRI scan. So you cannot wait for urinary symptoms to help you decide whether or not you've got prostate cancer or not. So it really is based on risk factors, age as you get older, ethnicity, Afro-Caribbean men, Ashkenazi Jewish men, and also family history, father, brother with prostate cancer. As if you have those risk factors really from the age of 45, 50, you need to be thinking about your risk of prostate cancer. And even without those risk factors, perhaps from the age of 50 and above, you need to be thinking about those risk factors and whether you have whether you should get tested for prostate cancer. I would say, you know, there are no UK national guidelines at the moment. There are some trials going on or about to start in the UK looking at this question, but I have written papers on what's called smart screening, where rather than screening everybody in the population, we look at screening at-risk individuals. So the risk factors really are age, ethnicity, and family history. So if you are a white man with no family history, then you might want to consider getting a blood test, a PSA blood test from about the age of 50. And monitoring that to see how the PSA changes, because the rate of change of PSA is very helpful in determining the risk of cancer, prostate cancer. If you're an Afro-Caribbean man, you want to maybe start that process off at the age of 45. If you have a positive family history with a father or brother with prostate cancer, you want to drop those numbers by 5 years. So if you're a white man with a father who had prostate cancer, rather than starting at 50, you start at 45. And if you're a black man whose father or brother had prostate cancer, rather than starting at 45, you start at 40. And you monitor the PSA. And if the PSA looks like it's rising reasonably quickly, then you'd want to consider seeing a urologist to have a scan and or an examination, and then determine the need for further investigations for prostate cancer. So that's a very good question, because PSA is stands for prostate specific antigen. So it indicates things going on in the prostate, not necessarily cancer. So lots of other things that can go on in the prostate that aren't cancer. Benign enlargement of the prostate, inflammation of the prostate, which is also called prostatitis, anything that causes the prostate to be squished. So cycling would be another thing. Recent ejaculation would be another thing. A urinary tract infection, any instrumentation, if you've had a cystoscopy or anything like that. So a number of things that can affect the PSA to go up that aren't prostate cancer. The problem is that most people rightly won't be able to differentiate between those things, which is why if you do have an elevated PSA, you need to see a specialist urologist, and especially even better if you can see someone who's a subspecialist in the field of prostate cancer or prostate diseases like myself, because then we can try and tease out whether this elevated PSA is a sign or risk for prostate cancer, or whether it's to do with many of these other conditions. So that's a really good question. Again, prostate cancer is a really kind of variable beast. It goes from being quite aggressive, like a Bengal tiger perhaps, to being quite benign, like a household pussycat, and everything in between. Because there's the adage that most men with prostate cancer die with it rather than from it. But equally, prostate cancer is the second commonest cause of death from cancer in the Western world among Western men. So you have these extremes. And it's really difficult for general urologists or general practitioners to understand how to differentiate whether this is a more aggressive cancer or less aggressive cancer, and those are things that will determine treatment. The other thing that will determine treatment is how far the cancer has gone. So is it confined to the prostate, or has it gone outside the prostate into nearby areas like lymph nodes, or has it gone into distant areas like the bones? Those things will affect treatment choices. And then the last thing that will affect treatment choices is how much cancer there is within the prostate itself. If the cancer is on both sides of the prostate, then things like focal therapy can't be used. If the cancer is in one specific area that isn't right at the edge, perhaps focal therapy, where you just zap the cancer with high intensity focused ultrasound or freeze it with cryotherapy, those are things that can be used. If, on the other hand, it's on both sides or there's more aggressive cancer, it's typically surgery to remove the prostate, which is something I'm an expert in, using robotic devices so that they're minimally invasive, allow the patients to go home the next day, have less side effects for patients, or even certain radiotherapy techniques, which might include what's called external beam radiotherapy, conventional radiotherapy given with hormones, or even what's called brachytherapy, which is placing radioactive seeds into the prostate to treat the cancer. So the good news about prostate cancer is that it is eminently treatable at pretty much every stage, and at pretty much every stage there's a good chance of a long lifespan after treatment, even if the cancer has spread outside of the prostate. There are lots of drugs available these days, abiraterone and enzalutamide and so on, for what's called metastatic or advanced prostate cancer. And there's also very good radiotherapy techniques for locally advanced prostate cancer, where the cancer has gone just outside the prostate. For cancer confined to the prostate, surgical techniques with robotic surgery has really revolutionized the treatment of prostate cancer, and has really decreased the side effects, especially when it's done in expert hands, because of course the robot is just a surgical tool, and there are plenty of people that use the robot perhaps who aren't as skilled as some people that have been trained with the best in the world and have done the operation many hundreds if not thousands of times. So there is a kind of operator dependence when it comes to surgery, but if you pick the right surgeon, generally outcomes after prostate cancer surgery are very, very good. So prostate cancer itself doesn't typically affect sexual function or urinary incontinence. What can affect sexual function and urinary incontinence is the treatment for prostate cancer. So if, for example, you're having hormone treatment because you've got advanced prostate cancer, or because you're having radiotherapy, and radiotherapy works better when given with hormones, the hormone treatment can affect your libido, which can of course affect your ability to have erections and so on while you're on the hormones. It can give you hot flushes and breast swelling and make you feel lethargic and things. So there are some side effects from the hormone treatment that can affect sexual function as well. Radiotherapy can cause an irritable bladder and make you rush to the loo more often, which can occasionally cause what we call urgency incontinence, where you have to rush, you can't get there quickly enough, and so you leak urine. So there is a little bit of that. But the main thing, I guess, that can affect sexual function and incontinence would be surgery for prostate cancer, because if, for example, you're removing the prostate, there are nerves that lie on the surface of the prostate that are important for erections, and sometimes the surgeons have to remove those nerves if the cancer is close or into those nerves, and that will affect sexual function. What it will do is it'll affect spontaneous erections, but you can always have things to help, whether that be tablets or sometimes vacuum pumps or injections that can help. The other thing is that there's a lot of continence apparatus, the stuff that keeps you dry around the prostate, the urinary sphincter, the bladder, the support structures to the bladder, etc. And those things can be damaged with robotic surgery as well, and that can affect urinary continence. There are certain techniques that I and others have researched and published on. I've done quite a lot of this work. Things like rectus-sparing prostatectomy, where you leave the bladder intact and the bladder attachments intact, and that improves the results of prostate cancer surgery hugely in terms of urinary continence. And in fact, I was cited as London's most influential doctor by the Evening Standard a few years ago for the work that I did in rectus-sparing prostatectomy that improves urinary continence after prostate cancer surgery. So there's a lot of work that myself and others have done looking at this area to try and minimize the side effects of surgery in terms of urinary incontinence and in terms of erectile dysfunction. There are certain techniques like the Grazer nerve spare technique or the NeuroSafe technique, again, things I've published on extensively, that can improve outcomes. So I think the key thing for prospective patients is don't be scared. If you have prostate cancer, go and see an expert who understands the field and who can provide you with the best level of care. And if that's surgical care, make sure you pick your surgeon wisely, because the surgeon is the most important variable in terms of your outcomes after prostate cancer surgery. So whether that is in terms of erectile function or in terms of urinary incontinence, and making sure the surgeon is very skilled at all the different techniques that will help preserve your sexual function and your urinary continence is, I think, really important to men's quality of life, and still getting the cancer out. So I think the final message I'd like to say is that if you have prostate cancer, understand that it is of course a complex subject and a very variable disease, but generally speaking, the outcomes are very good, especially if you go and see somebody who's an expert. And generally speaking, even if you need prostate cancer surgery, the outcomes are excellent and have minimal impact on your quality of life. Again, if you see someone who's an expert and highly skilled and very well trained in managing your cancer.